How's it look?
Yes, coming.
You coming?
Yeah, yes.
Okay. Yes. Just talk it. Make it there.
Can you start? Very good afternoon to all of you. Today we will be listening to Dr. Matthew Sterlo about undifferentiated shock, which makes making a difference. Dr. Matt is a Vice Chair Emergency Medicine, Director Stanford Emergency Medicine International, Stanford University. Dr. Matthew Sterlo is a very good, what we call as an academician, and he teaches. He has had a wide experience, and he has taught trained many of our PG PEX students here, and they have developed a team of ACEs. And we are very fortunate to have Dr. Matt here today to talk about this undifferentiated shock. He is not only a good teacher, but he is also a very good clinician. We had the opportunity to see his clinical work when we visited his hospital at Stanford. So with this short introduction, I request Dr. Matt to take over the dais and start about undifferentiated shock. This shock, actually, he was mentioning about this yesterday, that if it is diagnosed in the early stages, it will be the outcome of the patient will be very good. And he was mentioning about some of the literature and studies that have been done, where with very minimal invasive or what we call a non-invasive techniques, we can diagnose the patient when he is going into shock. Dr. Matt.
Thank you very much, Dr. Raja. It is my pleasure to be here at my very good friends and partners, EMRI, GHS, Green Health Services, as we continue our partnership between them and Stanford University since 2007. So I think we are now in our 16th year partnering EMRI and Stanford. And during that time, I've had the privilege of working and teaching and working side by side with many of the folks here in India and at EMRI, both in the pre-hospital and in the hospital setting. My work at Stanford centers around a number of things, including the global epidemiology of emergencies, and I have a passion for critical care and how we can take the concepts from the ICUs and use those concepts to better care for the patients in the emergency departments, the urgent care, the stabilization centers, and even in our clinics. Please let me know if if I'm having any trouble with the audio. But I think at this point, I'm going to get started. And I have a colleague here today with me, Dr. Enoch Obang. And Dr. Obang is going to take over. He is... Sorry, 1 second. I don't... Oh.
You've been muted.
You need to turn that off.
That's why I muted it. I think we might have to do that again. Yeah, I need them to mute. Can you mute them? Sorry, Dr. Raja. I'm going to have to start over. right. How about now? Thumbs up if you can hear me? All right, I see some thumbs. That's great.
Yes, please.
Excellent. You know what that means, right? That means that in only 2.5 years into a pandemic, I almost know how to use Zoom. That's really good. So, my name is Dr. Matthew Strelo. I am the Vice Chair of Emergency Medicine at Stanford University and a professor in emergency medicine. I'm the Director of Stanford Emergency Medicine International, and I am a proud and longtime partner and colleague of EMRI GHS. Stanford and EMRI have been working together hand in hand since 2007 to advance the care both in India but globally around pre-hospital and early hospital emergency care. My passion is for epidemiology and trying to figure out what's causing these emergencies, but it's also for critical care. How do we take the concepts from the ICU, apply them in the emergency setting, early for the patients, both in the pre-hospital arena, the emergency departments, and that very important transition from the emergency department into the ICUs in the hospital. So for the next 45 minutes or so, we're going to talk about undifferentiated shock, one of my favorite topics, and I brought along a colleague of mine, Dr. Enoch Obang, who is also a faculty at Stanford in emergency medicine, and will be speaking and bringing some of his ultrasound, his bedside ultrasound expertise to this talk. Let's go ahead and get started. All right. So what are we going to talk about? First, we're going to talk about recognizing shock. How vital are vital signs? What are some other markers of shock that we should be looking at, both in the pre-hospital setting, the emergency department setting, and beyond? Then we'll talk about the management of shock. There's been a lot of literature coming out about the management of shock over the last few years, and it's hard to keep up with everything during the pandemic. There's been things about vitamin C, thiamine, steroids, the amount and type of IV fluids, vasopressor use. So much literature out there, and we're not going to be able to touch on all of it, but we're going to touch on some big ones that are going to drive the care both in the pre-hospital setting, but also in the hospital setting. And then if we have time, we can touch on some of those other ones as well. And then we'll talk about what vasopressors and when to use vasopressors. So to get started, I like to think about what does shock really mean? Because for shock, many of us, we think about blood pressure, right? But Dr. Gross in the 1800s, a trauma surgeon in Napoleon's army, said that shock was the rude unhinging of the machinery of life. But a more modern definition of shock is that shock is inadequate tissue perfusion, right? Or occult shock, or also known as cryptic shock, is inadequate tissue perfusion without hypotension. So stated simply, shock is when you're not bringing enough blood and oxygen to the tissues for them to both get oxygen and get rid of the toxic metabolites. It's not. Importantly, shock is not just a low blood pressure. So let's talk about the early versus delayed recognition of shock. One of my favorite studies, so I know it's a little bit old now, was from critical care medicine. And in this study, they did a number of things across their whole hospital, inpatient hospital. But mainly it was around education, rapid response, rapid recognition, and some very basic protocolized care approach to shock. And what they found was that over the 5 years that they instituted this quality program, mortality decreased from 40% from shock in their hospital to 12%. They had no special new drug, no special new device. This was just early recognition and early basic intervention. So really, what does that mean for us? It means that early recognition of shock and basic intervention is the most critical feature to saving patients' lives. So shock, which kills a lot of people in the United States, in India, and around the world, is not just for the ICU physicians. Yes, they have to be experts in shock, but so do we in the ambulance and in the emergency department and on the wards. So let's talk about recognizing shock. And we'll do this with a case. This was a 70-year-old female. She came in with fatigue, no fever, heart rate 90, blood pressure 85/40, breathing 24 times a minute, satting 92%. She came from a skilled nursing facility. She was given 1 liter of normal saline. Her blood pressure improved to 100/45. Is she okay? Does that single low blood pressure reading in the emergency department really mean anything? Well, a number of studies have come out over the years, observational studies, and what they've shown is this thing that we see pretty commonly in the ED is that these patients that have that one low blood pressure below 90, they actually have a very high risk of going into shock. So that's a real marker. So if you see that one low blood pressure, you need to treat them aggressively and pay very close attention to them. The predictive value of that, of them going hypotensive, is even higher than an elevated lactate or bandemia. Right? So it's actually very predictive. So we know those patients that come in, their blood pressure's low, it's obviously shock. But these other patients come in, maybe they have a little bit of borderline blood pressure. They may be in shock too. Well, does that carry over to the ambulance? Many people in the room that I'm with today work in the ambulance. And can that same thing be said to be true? And the answer is yes. They looked at patients that had a low blood pressure in the ambulance, at least one, and then by the time they arrived in the emergency department, was their blood pressure was now better. It was no longer low, technically. So patients low BP in the pre-hospital, normal BP in the hospital when they arrive at the hospital. Those patients, their chance of dying during that hospital visit was anywhere from 12 to 50%. That's a big range, but it's also a big number. So that's a very high mortality. Whereas the mortality when there was one low BP in the ED was 12%. So these patients that are low in the field, low BP in the field, and then better in the ED at first, those are very risky patients, and we need to pay attention to them. We should not discount what is done in the ambulance. Many times I hear doctors say, oh, they probably didn't get the blood pressure right. It was in the back of the ambulance, this and that. That is wrong. The folks that work in the ambulances are very good, and they know how to take a blood pressure in the back of the ambulance. Just because you and I may not, doesn't mean they don't. So we need to pay attention to those patients. So any low blood pressure less than 90 definitely needs to be investigated. And you can carry that over, actually. Any low blood pressure less than 100 needs to be investigated. Or if the patient is normally very hypertensive, even higher might be concerning. So if we can't use blood pressure, we need to be able to use some other things. And there's these 4 markers that I like to think about and make sure that I'm checking on most patients that I'm worried about. One is the shock index. 2 is skin perfusion. 3 is urine output. And 4 is their mental status. So let's talk about shock index. This has been around for a long time, but it's been used a lot more over the last 5 years, and I'm very happy to see that. The shock index is looking at the cardiovascular system, and it's taking the heart rate and it's dividing it by the systolic blood pressure. Because normally, right, your heart rate is going to be like 60 or so, your blood pressure 120, so your normal shock index is about 0.5. But now because you're using this idea of the blood pressure and the heart rate together, you can see if there's compensation being attempted by the body. It's more sensitive for predicting shock and picking up early shock than using just heart rate and blood pressure separately. So in our patient, heart rate 90, systolic blood pressure 100, so that's 0.9 if we do our calculation, which even I can do. Normal is 0.5 to 0.7. Anything above 0.9 is abnormal and needs to be investigated and concerning. Now, some people said, well, does that count if the patient's hypertensive normally, if they have diabetes, if they're very old, if they're on calcium channel blockers or beta blockers? The answer is yes. It pretty much works in everyone. Pediatrics is a little bit different. It still works, but it needs adjustment. But for adults, it works. And if you want just a simple number, just use 1. Shock index of 1 and higher, not good. That your patient is at risk. Okay? Shock index in the 0.8 to 1 range, a little bit more risk, but anything over 1, very risky. So heart rate 100, blood pressure 100, that's 1, that's a problem. Next, we like to look at skin perfusion. And there's been a couple of studies, very nice studies done on this. And in adults, we have to use a longer capillary refill time. But you can also use touch. So if you feel the extremities of a patient, the feet, the hands, and they're cold, that's not normal, especially in India, in most places, right? So if you have cold hands or feet, or if the capillary refill is very delayed, more than 4.5 seconds, that patient, that's a sign of shock. The patient is starting to squeeze down, okay? There's been research showing high rates of organ failure in these patients and high lactates. Next is urine. The kidney is a great marker of perfusion, both late and early. And any ICU doctor will tell you that the urine output is very important. But we need to use it also. So we don't take the initial urine output. But if the patient is sick, we can put in a catheter. Don't worry too much about the initial urine, but you monitor it after that for 30 minutes or more. When you're resuscitating patients, you want to see more than 1 ml per kilogram per hour. So 70 kg person, 70 mLs out in first hour. Okay, it's different once you get upstairs a little bit, or a patient who's healthy and doing well, we might be okay with a lower number. But in a patient that's sick and that you're resuscitating, we like to see this number of 1 ml per kilo per hour. And then mental status. Many times the patient comes in, they're a little bit confused, and we just say, oh, they're just a little bit confused. But remember, the brain is an organ that requires perfusion. And if they're confused, you need to ask the family, is this normal for them or not normal? If the family says, this is not normal, you need to think that the brain is not getting enough blood flow. And that altered mental status is due to hypoperfusion and early shock. So in this patient, remember the shock index was elevated, right? And so we were concerned about her. She had the transient low blood pressure before we gave that fluids. So we did a lot of investigation, got a lactate, and it was very elevated. Anything over 3 is concerning, I would say. Anything over 4, very concerning. Chest x-ray showed a pneumonia. And even though she came in with no hypotension, right, or at least small hypotension that responded to fluids, just a few hours later she was on norepinephrine, 2 vasopressors, and vasopressin in the ICU, still in shock. It was just early, and so because we started resuscitating her early, she had a chance of surviving. So what is the bottom line in detecting occult shock? Remember, vital signs are late markers. If you wait for hypotension, you're waiting too long. Bedside markers, being a good doctor or nurse or paramedic or EMT is very important. So look for shock index, look for skin temperature and capillary refill, look at urine output and mental status. And then use lactate. You can use arterial base deficit or negative base excess as well, but lactate is simpler in many cases if it is available to you. And it might be a little bit more predictive in non-trauma patients. So lactate can help us look out for those normotensive shock patients. Now we need to search for causes. So now we've identified the patient is in shock, right? But how do we know what is the cause of shock? So here is a case of a 67-year-old man who came in with altered mental status. His heart rate was 120, blood pressure very low, respiratory rate very fast, satting 96%, right? What is the cause or etiology of his shock? Well, we spend a lot of time, if you're critical care and on this call, I know we've talked a lot recently in critical care and emergency medicine about obstructive shock and how to manage obstructive shock and right heart failure. And I am very excited about getting better at managing those patients, but those are only a small percentage of our patients, 2% according to the data. Whereas distributive shock, septic shock, hypovolemic shock is most of the patients. So obstructive shock is treated a little bit differently. Cardiogenic shock may be treated a little bit differently, right? Likely treated differently. But most of our patients, in these undifferentiated patients, are in these other categories where we need to figure out what it is so we can treat it. But when you give this big differential, this is all differential diagnosis or causes of shock, right? It's a pretty long list. And it's hard to remember each of these if we just put the big list together like this. So how good are we at this? Well, we're better than this study, but this study helps us understand where we're at a little bit. In this study, in the emergency department, how often were they able to determine the cause of shock in a patient who had undifferentiated shock? 25, 45, 65, or 85? Well, I am an emergency department doctor, so of course I would say 85. No question. Of course myself, 100, right? No. Even me, it's not going to be like that. 25% of the time, 1 out of 4 patients could they get the right diagnosis early on in the ED. That's a little bit low. I would think most of the time we're better than that. But funny, I think most of us, even Dr. Enoch and I were talking about this today, most of us that work primarily in the emergency department think that in the ICU, they can always get the diagnosis because they have some time and things. But that's not the case. There's been many studies that have shown that in the ICU, only 50% of the time, maybe up to 80% of the time, are they able to determine the cause of shock. It's a very difficult thing to figure out. Patients are complex. People are complex. So what can we do? Well, we have some tools available to us, right? One of these tools is ultrasound. And I know that ultrasound is becoming more and more popular. Point of care, bedside, we call it ultrasound. So in this study, by one of my favorite researchers in emergency medicine, Dr. Alan Jones, who's done so many smart studies, they looked and said, if we use ultrasound versus we not using ultrasound, could that improve our ability to make the diagnosis? And what they found was if they used ultrasound early in the management of the patient at the 15-minute mark, 80% of the time, they could get the correct diagnosis. That's really good. I'm not sure I'm 80%, honestly. But they gave them that whole list, and they were able to get the number even after 15 minutes in 80% of the cases with ultrasound. They were very good even without ultrasound 50% of the time. But still, 50% is only half, and making an improvement to 80% of correct diagnosis is very good, and that can help us drive care. The other thing is, even when they couldn't get the actual diagnosis, they were able to eliminate many causes. They looked at how many causes were still left in their differential diagnosis, and they went from 9 to 4 when they used ultrasound. Well, that's very important, because then maybe I don't need to send the patient to CT scanner or MRI or ultra echo, right? Because those things are risky in an unstable patient. So there's many protocols for using ultrasound to look at shock. I throw this one up because in the United States, this is probably the most popular bedside protocol. And it was done by a friend of mine, Dr. Pereira. But I will say that it doesn't really matter. I don't think any protocol is the answer. This one is better than that one. I think you just need to have a system for using bedside ultrasound. So the bottom line when we're looking at shock is, with ultrasound, it can help us make the diagnosis very quickly. And you need to have a protocol or an idea of how to use it, though, like what approach. Be systematic. There's rush protocol, falls protocol, blues protocol, all fine. But pick one and learn it. In this case, we gave this patient a lot of resuscitation, but he continued to do poorly. Normal saline, we put him on dopamine, which we don't use much anymore, but at the time we used dopamine. We did a rush protocol. He had a large pericardial effusion and pericardial tamponade. We don't do this very often in the emergency department, but in this case, because there was some delays to going to surgery, we did a pericardiocentesis, the vital signs improved, and the patient was admitted to the ICU. So the bottom line, vital signs, traditional vital signs, are late markers of shock. Okay? If you're waiting for the vital signs to look very bad, you're not treating your patient very good. Bedside indicators, shock index, cool skin, urine output, altered mental status, are early markers. Bedside ultrasound helps us identify types and causes of shock and categories. Now, there are a lot of other tools before we go on, besides ultrasound, to help us look at shock, muscle tissue oxygenation, sublingual capnography, right? Skin tissue, mirrors, all these different technologies. But none of them have been proven to make major outcome differences. But if you're using them, the ideas are good behind those. They're called regional markers of hypoperfusion. We can talk more about those if there's time at the end. All right, so let's go on to management. We have an 80-year-old female with altered mental status and hypotension. She comes in, and because of that altered mental status and hypotension, we're pretty sure she's in shock at this point. We give her a bolus, 30 mLs per kg IV normal saline. So in her, that's about 1.8 liters or 1,800 milliliters bolus. We repeat her vital signs. Heart rate now is 60, blood pressure 85/45, respiratory rate 20, satting 95%. Shock index, not good, right? So blood pressure, not good. So in this patient now, the question we ask ourselves is, should we give her more fluids? Should we start vasopressors? That's the question. So there's been a lot of research into this lately, and I'm excited because of that. The most recent large trial that came out was this one. Just this past year, about 6 or more months ago, in the New England Journal of Medicine, they took 1,500 patients and put them into 2 groups. One group restricted IV fluids, where they kind of watched, and they did not give IV fluids unless they could prove the patient needed them. The other group, the usual care. Now, why would they do this study? Why do people care? The reason we care about this is our poor ICU doctors. If you're in the ICU, I feel bad for you right now because, or not now, but in the past. Because there was a long time where we, in the emergency departments, were just pushed, with the ICU doctor's permission, of course, together as a team, we were pushing lots and lots and lots of fluids. My friend Dr. Rivers, Manny Rivers, Brian Nguyen, they did the early goal-directed therapy research, good research, but it also started us to really push IV fluids to the point where the patients were getting so much fluid, they were getting fluid overload. And we know now that patients that have a very positive fluid balance after 24 hours and they're in the ICU have higher mortalities. So we don't want them to get too much fluid. We don't want them to get too little fluid. We want them to get just the right amount. That's hard, right? We have to think. We can't just give. We can't not give. We have to think. And we've learned that if we don't think and find the right amount, our patients, when we give too little or too much, our patients will do badly. So this study said, well, can we really reduce the amount of fluids we give to our shock patients safely? So with these 1,500 patients, they did not find any difference in outcomes if they were in the give the normal amount of fluid group or give the low amount of fluid or restricted group. They did find, though, that before they enrolled the patients, which they enrolled the patients early on, the patients had already received 3,000 milliliters or 3 liters of fluid before enrollment. After they were enrolled in the first 24 hours, the restricted group got 500 mLs. The usual care got almost 3 times that. They got 1,300 mLs. So add that together, 3,000 plus 500, 3,500 versus 4,300. Those are normal amounts. Like 4,300 milliliters of fluid in the first 24 hours is not more than we give. It's an amount we give regularly. But there was no difference in outcomes. And that study that just came out showed that we can find restricted fluid approaches that are safe for our patients. Now, do we need to give this initial IV fluid bolus? This is a question we've been asking ourselves for a while. Here is my thoughts on it. There is no great evidence. But here is my thoughts on it from reading the evidence that does exist. Most ED patients benefit from an initial fluid bolus. If you are an ICU doctor or you work in the ICU and your patient's already gotten that bolus in the emergency department or in the ward of the hospital, they may not need that first bolus. They don't always tolerate the first bolus. But in the ED, almost all of the patients tolerate that initial fluid bolus of 20 to 30 mLs per kilo. Oftentimes, because of history of a past medical history of CHF or renal insufficiency, we don't give that first bolus. Those patients that don't get the first bolus in CHF or renal insufficiency, not patients in heart failure right then, but who have chronic heart failure. Okay? The lungs are not wet right then. In those patients that don't get that first bolus, they tend to do worse. So we do think that first bolus is helpful for most ED patients. When would I not give the first bolus? I wouldn't give the first bolus if the patient obviously has wet lungs, either by auscultation, by oxygen saturation in history, or by ultrasounding their lungs and seeing, or by chest x-ray. But everybody else you give the first bolus. But how about those second boluses, right? How did they decide whether to give that second bolus? What was the fluid-restricted group? How did they get the 500 mLs? Well, they said if the fluids led to improvement in hemodynamics, so if you gave fluids and something improved, then you could keep giving fluids. But if you gave fluids and nothing really improved, stop giving fluids and give something else. Makes sense, right? But how do we do that? How do we make that decision? So this was a study that was just published, actually, recently in the last year in CHEST. 124 patients. They randomized them into 2 groups, an intervention group and a control group. They put twice as many people in the intervention group. It's one of the more modern trial designs, right? And then they tried to say, instead of just giving more fluid if the patient is hypotensive or in shock, we are going to do a fluid responsiveness And if they are fluid responsive, meaning you give small bolus of fluid, they improve, then we'll keep giving fluid. But if they don't improve, we'll stop giving fluid.
And here is
their algorithm,
but I can
break it down pretty easy. They did a passive leg raise to determine if the person to give the fluid bolus, and then they looked at stroke volume to determine if the patient was fluid responsive. So we're going to talk about this because this is really important for our care. So what they did was they measured cardiac output. In this case, the stroke volume is part of that calculation, which we'll talk about. Then they did a passive leg raise, and then they measured cardiac output again. Pretty simple. What is a passive leg raise? A passive leg raise is where you take the patient who's semi-upright or upright, and they have been like that for at least a few minutes. And so when you do that, when you sit like that, right, the blood will pool in your veins of your legs, and in your abdomen a little bit maybe, but mostly in the veins of your legs. And then when you drop the head of the bed down and you raise the legs, what happens? The blood from the legs and the veins comes back, and the heart feels like it got a little fluid bolus. They have done lots of looking at how much is that fluid bolus, and it's like giving a fluid bolus of about 300 milliliters, somewhere between 300 and 500, but 300 mostly. That fluid bolus, though, is transient. Because when you do this, it comes to the heart for about 30 to 90 seconds, and then it gets redistributed into the gut veins, blood vessels. And so it's not like you're giving a permanent fluid bolus that you can't take back. It's already in the body. So it's a nice way to challenge the heart with a little fluid bolus. And here is an example of that. So here's the lady, she's sitting up. We are checking her vitals very carefully, her blood pressure. We check her blood pressure. We check her end-tidal CO2 in this case, but it's not accurate because she's not sedated, paralyzed, and intubated. We drop her head of her bed. My doctor friend raises her legs to 45 degrees, and then we leave it there. And we know that between 30 and 90 seconds, we should see a bolus of fluid to her heart. So after 60 seconds, we repeat the blood pressure, and you can see that her blood pressure has increased now to 107. So she got a little fluid bolus. We actually saw an increase in end-tidal CO2 also, but she got a little fluid bolus, and we saw the blood pressure increase. And that's what they did here, right? When they did this approach of letting the fluid responsive, we call it. So you give the fluid, the patient responds in a good way. Fluid responsive to drive care versus the usual way that we do it. What they found was that patients did not have so much positive fluid balance after 24 hours. Right? We don't want them to be too fluid positive in the ICU because it's hard on their lungs. It's hard for the ICU colleagues to manage that. They have to try to get that fluid off, which is hard. And so what they found was after 24 hours, the group that had the passive leg raise driven decision was only positive fluid balance about a half a liter, 0.65 liters, versus the usual care arm was positive fluid, meaning they had gotten 2 liters more fluid than had come out. So their body was positive 2 liters of fluid in the normal control arm. This study was not powered. They didn't have enough patients to look at things like mortality, ICU length of stay, right? Need for intubation, length of time that they were intubated. Didn't have enough patients for that. But all of those markers, all of them looked better in the group that did the passive leg raise to help them drive the decision. Every one of them. So it was very exciting to see because we've been thinking about this for a long time. So the passive leg raise is an easy way to do it. You can do the passive leg raise. If your patient can't get the passive leg raise, then just give them a small bolus of fluid and do the same thing. The hard part has always been trying to figure out how to measure cardiac output to see if the patient responded. And there's like a million ways to do it. There's pulse differential, bioreactance, Doppler monitoring, stroke volume variability, etc., etc. And there's a lot of technology. In this study, they use bioimpedance across the chest, which can help you get the stroke volume. Fancy technology, we don't have it in the emergency department at Stanford. There's also some new technology that just goes on the finger that looks at pulse wave differential and has a fancy algorithms to help read it. And so there's a lot of ways, technology ways that we can do this, but some of this stuff is hard to get. You can also use, and this is actually, I made this slide based on many studies, but they're all small studies. But I made it to figure out what is the best way to measure cardiac output improvement in patients when I don't have the fancy technology, using just either end-tidal CO2, using blood pressure with or without central venous pressure. And I had made this slide to help myself. But it's still very complicated. And it's hard to follow for people. So we now have another way of doing it. Another way that's available to most of us, ultrasound. So I'm going to turn the microphone over to my esteemed colleague, Dr. Enoch Obang, who is very good at this and teaches it both in the United States but also in Africa, and is going to teach us a little bit today.
So as Dr. Matthew mentioned, I'm one of his colleagues at Stanford, and I'm just going to talk briefly, very briefly, about how to measure cardiac output. This is easily a whole lecture by itself, but the point of it is just to show you that in just 6 easy steps, you could potentially measure cardiac output and use that for your care or driving your care of those undifferentiated shock patients. So why measure cardiac output? It's diagnostic, more reliable than some other measures of secondary measures of potential end organ perfusion or shock. And it is, like mentioned previously, therapeutic. We can use it to, that measurement to determine if we're having fluid responsiveness. And obviously we're giving medications for these septic patients to augment that cardiac output. So it would be helpful to know. So first, some basic math, very basic math. You don't have to worry about this. The ultrasound machine will do all the work. But just realize that cardiac output is heart rate times stroke volume. The volume is something important to realize. And so the volume will essentially be the volume of a cylinder. And I'll have a picture later explaining that a little bit more. So cardiac output, heart rate times stroke volume. Cardiac output, heart rate times stroke volume. Stroke volume is our LVOT is left ventricular outflow tract. So we take that cross-sectional area and then multiply that times the velocity time interval. And I'll show you in a little bit how the ultrasound machine will do that for you. So like I said, volume, we're using the volume of a cylinder to measure that stroke volume, which we'll then use to find our cardiac output. If you notice how that cylinder tucks in right at that left ventricular outflow tract, that's where we're using our volume calculations. And so we'll have to, step one, we just need a parasternal long axis view, which you can see here. And then that next step is getting that left ventricular outflow tract diameter. That diameter will be plugged into the equation you see on the right, but your ultrasound machine will do that for you. You just have to be able to get a parasternal long axis view, be able to mark that left ventricular outflow tract and let the machine do the rest. Next, you'll need an apical 5-chamber view. They sit at 5th chambers, that aortic outlet where you get that left ventricular outflow tract. And this is just a more reliable way to get our next measurement. So step 1, peristome long axis view. You want to measure that left ventricular outflow tract diameter. Let the ultrasound do the rest of the work. You'll switch to this next view. And then we'll place Doppler at that left ventricular outflow tract. Let the machine do the work. And that's exactly what you would see here. And then the last number you need is heart rate. You can measure it on the machine. You could just look at the monitor, keep it simple. This patient's 78, probably needs a little oxygen, but the heart rate, now you have all the numbers you need. And so this next part is just calculate. We have our heart rate, we just look at a monitor real quick, we'll get that on the ultrasound. We have our stroke volume. We did our 2 numbers that the machine was able to calculate, and we just put it all together. And then we're able to get that cardiac output. So just to summarize, just to prove it's just 6 steps. You get one ultrasound view, you get your left ventricular outflow tract diameter, you'll switch to that other view, that apical 5-chamber, you just place Doppler at that left ventricular outflow tract, you calculate the heart rate, or you're even given the heart rate, and then literally the machine, the ultrasound, will calculate all that for you. And so now we are able to have cardiac output and drive our care more appropriately. There's no need to guess. We can have a number that tells us cardiac output. And so I'm going to pass this back to Dr. Matt.
Thank you very much, Dr. Enoch. You know, that can be intimidating, but the key there is that most of the ultrasound machines now can calculate this for us if we can just get those views. And they're views that we are obtainable. So then we can get that cardiac output, and then all of a sudden we have the ability to check fluid responsiveness, right? We can do a passive leg raise, give that small bolus, calculate our cardiac output, and see if the cardiac output improves. How much does it need to improve? In that research study I just mentioned, published in Chest, it needed to improve. They used 10% improvement in cardiac output, right? And I think that's pretty normal. Most research studies say someone is fluid responsive if they have an output increase, or cardiac output increases by 10 to 15%. So how do we manage fluids in our undifferentiated shock patient? First, if the patient is volume overloaded, they have wet lungs, on exam, on history, on ultrasound, on chest x-ray, if they are already wet, don't give them more fluids. That's only going to cause problems. Just start with vasopressors directly. Okay, that's more common in Australia than it is in the United States, but it's definitely the approach you want to take when a patient is volume overloaded. Second, if they are not volume overloaded and you're in the emergency department, go ahead and give them that fluid bolus. Now, if they have a history of severe heart failure or they are dialysis dependent, maybe you don't want to use 30 mLs per kilo. Maybe you want to use 10 and then recheck them, and then 10 more and recheck them. Remember, it's about rechecking patients. So don't order 30 and never check them. You have to be checking them the whole time, looking to see if they get volume overloaded. If you're in the inpatient side, it's less clear that they need this fluid bolus. You have to really assess the patient carefully. Secondly, third, after the fluid bolus, see if their shock is improved. Check their vital signs, their shock index, their urine output, right? Their mental status, their skin signs. If they've improved, observe them for nearly all patients. Use that passive leg raise or 500 cc bolus to measure and then an increase in cardiac output, stroke volume, right, which correlates well with cardiac output because the heart rate stays the same most of the time when we give fluids by more than 10%. Now we know we want to give fluid sometimes, but we still have to ask ourselves, what is the best fluid strategy? Should we give albumin, balanced crystalloids, unbalanced crystalloids? Normal saline is considered an unbalanced crystalloid. Ringer's lactate, plasmolite, and other ones like that are considered balanced crystalloids. Or should we use the starches? Now, most of you won't say starches because the starches have been shown to cause problems like renal failure and things. A few years ago, in 2018, another study came out showing that balanced crystalloids would maybe be better than using normal saline. And there was a combined reduction in death and need for renal therapy and renal dysfunction. And this was one of a number of smaller or less not randomized control trials suggesting that we should be using balanced crystalloids over normal saline. So in places where that was available, a lot of us switched to at least when we're giving lots of fluid to not just giving normal saline, normal saline, normal saline. But the research wasn't super clear. And a paper just came out about in 2022, very big study, randomized controlled trial, 5,000 patients. They compared balanced crystalloid, okay, where the amount, where it had more physiologic amount of salt in it, versus saline, which is hypertonic, has more salt than we do in our blood. What they found was no difference in outcomes. In this study, the normal saline did not cause problems. So what's the answer now? It's a little bit more difficult. But I would say this. If you have balanced crystalloids available to you, I'd probably still use them. If they're much more expensive or you don't have them, it is fine to use normal saline. So you start with your fluid, you give crystalloid, could be normal saline, could be balanced crystalloid, you give that bolus. If you're giving a lot of fluid though, I would still suggest using balanced crystalloids like lactated ringers. There are a few patients that we think of maybe we should give something else, right? Our liver failure patients and our bleeding patients. So within the last like 1 to 2 years, a couple other big studies have come out looking at this. In this randomized control trial, they looked at 20% of 100 patients, so not a big study, but still randomized trial, 20% albumin versus balanced crystalloid, plasmolite in this case. And what they found was that when you gave the albumin, right, to these patients who have cirrhosis and liver failure, they had more rapidly, they resolved their shock, I should say their hypotension, sorry, when they got the albumin. However, there was no difference in mortality and no difference in clinically oriented outcomes otherwise. And with the 20% albumin, like 11 or around 11 to 15% of them actually developed pulmonary edema or difficulty breathing due to the fluid on the lungs. So it did not seem that the 20% albumin was helpful enough to balance out the problems it was causing. And the recommendation here was that we probably shouldn't be using 20% albumin for our cirrhosis patients. Now there's been some other studies looking at 5% albumin that have shown that that's better than normal saline. So it's not clear at this point for our cirrhosis patients what's the best. I think it's okay to just use crystalloid for now. You can consider 5% albumin if the albumin is very low, okay? That is fine. But I wouldn't use the 20% at this point. What about blood products in our bleeding patient? Well, we know for a long time we've been told if they're losing blood, replace blood. But people have been saying, well, how important is that? Should we give them any fluid other than blood products? So in this trial, this was a randomized control trial published in the Lancet of Hematology of 432 patients in the ambulance pre-hospital, and they had experienced trauma. And they compared a liter of normal saline versus giving RBCs and plasma. And they found no difference in mortality at 3 hours or 30 days. There were a few things that looked better in the blood products group, but overall the mortalities were not different. So I would take from this trial that yes, we give blood products if you're bleeding. But it's okay to start with a small amount of crystalloid in the ambulance and early in the emergency department. Okay? We don't want to give 3, 4, 5 liters, but 1 liter, maybe 2 liters, okay. Probably 1 liter, okay. But after that, let's switch to blood. But it's not that we should be trying to spend lots of money to push blood products into the ambulance at this point. So our choice of fluid resuscitation, right? So balanced crystalloids, even normal saline is probably okay. Consider albumin for cirrhosis patients, maybe, but it's not clear that it's better. And if you do use it, use 5%, not 20%. And blood products for bleeding patients, but you can start with a little bit of crystalloid. So in this patient, she got 1,800 mLs, or 1.8 liters of normal saline. We did the passive leg raise, and she was fluid responsive, so we gave her another 500 mLs. We put in a central line. At that point, we determined we did a passive leg raise again. We used Dr. Obang's recommendation to calculate cardiac output, looking for that 10% increase with the passive leg raise in cardiac output. And we did not see that improvement. It did not increase by 10%. And her breathing started to get a little bit more wet. So at this point, we stopped the fluids. Okay? So we got to stop the fluids because she's not responding to fluids anymore. And we don't want to keep giving fluids if it's not helping and it might be harming. So now which vasopressor do we give? Well, these have changed over time, but it's a little bit more simple right now. Norepinephrine is first-line vasopressor therapy. Multiple studies have shown against dopamine, against epinephrine, against others, that norepinephrine does well. It's at least as good. So to simplify things, I like to start with norepinephrine in most cases, or noradrenaline is the term typically used in India. If the patient is not improved with noradrenaline, obviously you want to increase it to a certain point, but if you've increased it and if the patient's not getting better, at that point, I like to think, are they in cold shock or warm shock? Right? Are they very clamped down, or are they very vasodilated and they have very bad distributive shock? If they are in cold shock, you can either add a little bit of dobutamine to try to vasodilate / increase cardiac output, or you can switch the patient to epinephrine. If they're in warm shock, a small fixed-dose vasopressin is recommended and works well, and we use it frequently at Stanford. I know there are places that still start with epinephrine for certain things, but I think in most cases noradrenaline has more evidence. The question then, and what I want to talk about being new, is this has just come up recently, is can we infuse the vasopressors through a peripheral IV? We don't always have the time or resources immediately in either the hospital or in the emergency department or the ambulance to put in a central line. And when I was training, it was said that if you put noradrenaline through a peripheral IV, the person's arm would turn blue and fall off, right? They would lose that arm. But now we've got more evidence, and there's a lot of small studies or observational studies, and this was put together in a systematic review and meta-analysis, and it showed that there was a very low complication rate of using vasopressors through a peripheral IV. And so it was the take-home message was that it was safe to use vasopressors, including noradrenaline, through a peripheral IV. I would say up to 24 hours. Preferably, you change that by 6 hours. But if you have to push it out past 6 hours, that's okay. So you can start them through a peripheral IV. The closer the IV, the better. So the bigger the IV, the better. Better not to start it in the hand, better to start it in the antecubital area. Try to get it to the antecubital area instead of the hand, but it is safe to start. All right, so our follow-up with this patient, she got 2 liters of NS, she got 2 liters of LR, she got a little bit too much fluid actually, and she was no longer fluid responsive. We started her on a norepinephrine drip or a noradrenaline drip. She got a little bit better and went to the ICU, but she remained very fluid positive, and we probably should have been more attentive to using Dr. Obang's recommendation for monitoring cardiac output. So in summary, detection and diagnosis are key. Early detection of shock is the most important thing that you can do, whether that's in the ambulance, in the emergency department, the ICU, or the ward. Hypotension is a late marker, and we have these other markers of shock index, urine output, skin signs, and mental status that can help us. We want to give that initial fluid bolus for most patients that are not in the hospital, that are in the emergency department or the ambulance. And then we want to not just give more fluids if the blood pressure is low. We want to think about it and see if the patient is fluid responsive. All right? And if we're going to give a lot of crystalloid fluid, which is the fluid of choice over albumin or starches for most patients, I would say if you're giving more than 2 liters, I would still recommend using balanced crystalloids, right, to avoid that hyperchloremic metabolic acidosis or hyperchloremic acidosis. And then for vasopressors, norepinephrine remains first line, and a peripheral IV is safe to use. So I'll end the lecture part here and say defer no time, delays have dangerous ends, according to our esteemed poet and author, Dr. William Shakespeare. So thanks everyone both in the audience here and online. I know we didn't get a chance to talk about some of the other really exciting things that have been coming out in the literature around vitamin C, around thiamine, questions about whether we should be using steroids or not regularly. There's just so much. The question of what blood pressure targets should we be using for MAP targets, and I'm happy to answer a few questions if I can in the chat, or you can unmute yourself and ask. I think we have about 5 minutes for questions. Yeah, so I'm looking now. It says, can we have a recording of a webinar? Yes. I hope so. The last one. Is it okay to start with 2 large bore IV fluids in shock patients, irrespective of the type of shock? Yes, I would say yes. So if the patient is in obstructive shock, so they've got a tension pneumothorax, they have a large PE, or they have pericardial tamponade, giving a large bolus of fluid is probably not the answer. Tension pneumothorax, you have to decompress it. Pericardial tamponade, you have to probably not give more fluids, but deal with the pericardial effusion. And you're going to send the patient into right heart failure if they have a very large PE and you give them a lot of fluids. So in obstructive shock, which is a small percentage of our patients, you have to be careful. But for most of our patients, including those with chronic heart failure, as long as they're not in acute heart failure, meaning their lungs are not wet, you can start with that 2 large bore IVs, drain in the fluid 1 to 2 liters, right, 20 to 30 mLs per kilo. But you have to recheck the patient, okay? If you do that in every patient, you're going to give too much fluid to some of them. So you really need to be checking the patient every 500 or 1 liter to make sure. And then after that initial fluid bolus, you should be very careful in giving fluids after that. I hope that answers your question. Thank you for putting one in the chat, and I'm happy to take some more.
Actually, when we go for this DHPT training, was designed by you. Frequently asked question is how accurate is the shock index, because if you take children
Hi, Dr. Vin here. Simple question. If we raise the lens,
Yes.
the blood pressure is going to improve. Is it going to be transient or is it going to sustain elevation of blood pressure?
So I got two questions here, and I'll answer them both. The first question is, if we raise the legs and the blood pressure improves, right? Because we raise the legs, it gives the blood bolus, fluid bolus to the heart. The preload gets up. Maybe it pushes out a little bit more blood then because increased preload, increased stroke volume. So if you raise the legs, it's transient though. Because what happens is after 1 or 2 cycles, that blood redistributes from where it was in the legs and it pools into the gut, into the abdomen. And so the blood pressure will drop after about 90 seconds. So if it goes up, it only goes up for a minute or two, a couple minutes, and then it goes down. So it's really a test. It's a way of giving a fluid bolus, but it's one you can take away. Versus if I put it in IV, 500 cc's, there's no way for me to take it out without cutting off the patient's arm and letting them bleed, which people tell me not to do. So, and then there was another question that comes up, it sounds like frequently. Dr. Raja, just remind me again, what is this? Oh, the shock index, yes, the accuracy of the shock index. The answer to that question is not very accurate. So it is more accurate than a heart rate or blood pressure alone. Okay, it's more sensitive. It will pick up shock in about 70% of your patients, 50 to 70%. It will be abnormal and suggest shock. Whereas if you lose heart rate and blood pressure alone, separately only, you pick it up in about 30 to 50% of your patients in shock. So it adds a sensitivity of about 30%. So about 1 out of 3 patients, using the shock index, or 1 out of 4, you'll pick up shock when you may not have otherwise. However, that still leaves 30, 40% of your patients, which the shock index will be relatively okay, and the patient still has other signs of shock, such as an elevated lactate, cold skin. Now, so the answer is, it's better than what we have from just the other vital signs alone, but still not great. But it is easy, so I do like to still do it. And then in children, in children, you have to use a pediatric shock index. And there is a research paper that just came out about this, and I'm blanking a little bit, but it also works in children, but it's not quite as good because children's heart rates are more variable. So the physiology is a little bit different, and you have to use different numbers. And to be honest with you, right now, I can't remember those numbers, but I can send the paper that just came out recently about it, and it showed that the pediatric shock index does work. I think you have to use a cutoff of like 1 or 1.1, and it's age dependent. So if the child is very young, you use 1 cutoff. If the child is a little bit older, in that like 2 to 7 range, use a different cutoff. And above like 7 or 9, use the adult cutoffs. Yeah, in children it's a little bit different depending on if they're very young, like the baby, newborn, or infant, versus a toddler, versus a teenager, right? And so you do use a cutoff variation, and it's a little bit higher, but I can send that to you to get the actual details. Great question, though. Would you do a pericardiocentesis? I got another question here. In a patient with shock, with type A dissection with tamponade. All right, this is a fantastic question. Thank you for asking. I will say this. My answer is no. You could. If you're there and you have nothing else, you can try it. I have tried it a couple times. The patient always just dies right there. So if the surgeons are ready to take the patient immediately up to the operating room, and they need 1 to 2 to 3 minutes, right, of time, and that's what you need to give them, then you can try to do a pericardiocentesis in a patient who has had a dissection back into their pericardium, and now they have a pericardial effusion, pericardial tamponade, the heart is being squeezed. You can stick a needle in there and draw out some of the fluid. The problem is that fluid is going to refill very fast with blood. And so my experience has been you draw it out, nothing happens, you draw out some more, nothing happens, the patient dies. I've only tried it twice, and I have not tried it once or twice as well when the patient was dying. But I tried it when I knew that the operating theater was ready for the patient. I will say this, though. My caveat is this. I listened to a talk the other day by a colleague in the eastern part of the United States. And in their talk, they said that they had a case like this, and they were able to draw out the fluid, and the patient lived. I have not asked them in a private room, is that true? So maybe it can be done, but my experience has been it's not successful. And I would think you're probably not going to be successful. So if you don't need to do that. But if you're sitting there and you need 1 minute, you could try. At that point, the patient's likely going to die. All right. Any other questions? Otherwise, yes, sir.
Is there a role for vasopressor in trauma? I know it's a but I'll be more specific. For example, I start my resuscitation shock patient with crystalloid, and obviously the patient still must be in shock. And my logical next step would be go for blood. But if I don't have blood, and if I have enough fluids, is there a place for vasopressor at this point while I wait for the blood, or while I wait for the patient to be transferred to the next appropriate center?
Yeah, that's a great question. I'm going to start with the admission that I haven't looked at the research on this very, very recently, but I have a pretty good understanding of it. But I can't say I've looked at it a lot in the last few months. And the question was this, I'll repeat for online. Would you ever give vasopressors if the patient is bleeding out in a trauma patient? Is there ever a role for it? My answer simply is yes. I think there is. I think that my Australian colleagues are a little bit ahead of us, and some of the ICU and trauma doctors in the emergency, across the world are probably a little bit out front of the emergency department doctors on this one. But I think that in the setting where you've given a little bit of crystalloid and you don't have blood right there, you might want to use some vasopressors, try a little bit of vasopressors to avoid just keep giving crystalloid, because we know the more crystalloid we give, the more bleeding we're going to get. And so there is some people and some literature suggesting, it's not super strong and it's relatively early, that we could give some vasopressors and avoid giving crystalloid, and that would be better. I think there are some people even saying that you could even give it with blood. I'm not ready for that. I don't know that enough. But I do think that in that setting that you said, which is you've given a little bit of crystalloid, you've given 1 to 2 liters of crystalloid, you don't have the blood quite yet, can you try vasopressors? I'd say yes. You probably need to do a combination, but you don't want to just flood them with 5, 6, 7 liters of crystalloid, because they're just going to bleed and bleed and bleed and bleed. Great question, though. Nice. In the UK, can I ask you, sir?
I have never come across this situation, but I think we do this in a lot of places in India. But in the area, I think those have
there you go. Well, it sounds like this is being done in India, so I think you are on the cutting edge here. Because I do think that if you asked me in 3 years, would the research, 3 to 5 years, is the research going to show that that's an okay treatment plan? I would say yes, probably. Not 100%, of course. Maybe 57%. All right. I want to thank everyone for your time, both online and in the audience. I really appreciate it. I want to thank Dr. Obang for his fantastic addition to fluid responsiveness. Thank you.
Thank you, Dr. Matthew Sterlo. I'm Dr. Rama Rao, Director of Emergency Medicine Learning Center at EMRI. We are very happy that post-COVID we are able to have these direct CME programs. All of you are aware that EMRI's vision is saving lives. We leverage technology. We believe in synergy of multiple technologies. With Stanford, we have been working on education, care, and research. While the Stanford reflects the global leaders in terms of creating things, innovating things, and discovering things. The topic today, the undifferentiated shock, is something I think we have started in the right earnest in the post-COVID situation. I just wanted to represent all of you here, either in this hall or those who are virtually available to this discussion. What impressed me was the communication with which both Dr. Sterlo and Dr. Enoch, they have modulated in terms of their regular American diction. Most of us were able to appreciate the essence of the scientific conversation. I also impressed with the flow of presentation. In spite of being a very complex topic, they have made it very clear so that our unknown to known, simple to complex, I think, like me, many of you must have appreciated in the last 1 hour. I've just seen the usage of the technology also. They have used some slides in between. They have also seen some videos. I think they must have done a reasonably very good homework so that they are conversant in terms of what they are going to bring to our notice. They were able to handle the questions properly, and they were candid enough to say that this is what I know, I do not know. And please remember that the strong message for all of us is that their evidence-based statements out of a very complex topic today we are discussing. So this is at the general parlance what I am sure that you will agree with me that these are the take-home messages at a generic level for all of us. Whether we are a basic pre-hospital care provider or an advanced pre-hospital care provider, and I see many of the people who are all involved with the instruction of the pre-hospital care, and I also see some of the emergency physicians who have joined from other professional groups in this Zoom and other virtual mediums like YouTube. The message is very clear. They have put the entire discussion into 2 parts in how quickly we'll be able to recognize and then what are the standards for the management. There are very crisp take-home messages for a pre-hospital care professionals like most of us who are sitting here in this audience directly, that please, we have to depend on vitals. And if we look for a very low blood pressure, and the message is very clear that we are talking about very late or recognition rather than the early recognition. So please, let us all be very careful. So vitals and abnormal vitals are very important and they were referring to the blood pressure as one important message. There were some trades and the tricks of the trade like raising the legs, and which is possible, and we are talk about position in the pre-hospital situation. And then we have been accessing veins, and then we are encouraging all our patients which are likely to go into shock or early shock, whatever the manifestations are there, because our EMTs, we are asking them to quickly identify, truly identify, accurately identify the critical cases. So please remember that this sort of a message is what have emanated out in terms of the blood pressure being very low is a very late predictor of the shock, very important. So use the crystalloids very properly, take the direction of the doctors, ERC physician. If you are working in ECC, you have access to these vasopressin. Some discussions have happened, and then they were kind enough to use both the Indian words for a drug and the American words also, epinephrine and norepinephrine and noradrenaline. Please remember that these are very important. And if I go to the emergency medicine department, very important that what can be done by looking at the clinical parameters, what can be done by using some of the bedside things. Very important thing is that we can definitely encourage the use of ultrasound and then I'm very happy that in addition to some of the standardized terminologies like the shock index, we can also now encourage emergency physicians working in our ED departments to use of ultrasonography. In fact, without making it very explicit, Dr. Matthew Sterlo has mentioned that all quality emergency departments must have to use ultrasonography vis-a-vis any kind of shock. So good questions from audience, and I'm sure that there are important things for all of us that we need to study the pathophysiology of the cardiac output. We need to understand some of the basic dynamics when we try to either assess the patient or take the right action. Thank you once again. I want all of the people who are there in this August audience directly to put a round of applause on those who are there. Unmute and then thank Dr. Matthew Sterlo and Enoch. I like your passing on the baton. Very smoothly you were able to explain. A great learning, great experience. Thank you so much. Thank you to the technology who organized this things, right? Here we end the session. Thank you once again.
Stand up for a second.
Sir, may I give you your places? Come on this side.
I'm going to take this off.